much for the opportunity to present our recent work on behalf of the neurosurgery team of Philipps University of Marburg. I would like to present our recent study. This study, pedicle screw instrumentation is a common procedure for the management of degenerative and infectious and oncological spinal disease. Freehand and fluoroscopic guided pedicle screw placement are traditional methods, whereas navigated guided pedicle screw placement, either with surface-based matching or automatic registration with intraoperative imaging. Additional robotic-guided pedicle screw placement have emerged in the past 2 decades. Navigation and robotic-guided surgery shows increased pedicle screw accuracy placement. And that's why we aimed with our study to compare the accuracy, revision rates, and screw loosening rates of fluoroscopy. Intraoperative computed tomography was also included in the comparisons. To our methods, we performed a retrospective single-center study, including consecutive cases who underwent pedicle screw placement in one of the 3 techniques by 2 neurosurgeons. The placement of each individual pedicle screw was evaluated in either intraoperative CT or postoperative spine CT, and subsequently classified using the Great Spine and Robinson system, JRS system, Sadishevsky classification, and Hare classification. Follow-up and postoperative CT scan were performed at a mean period of 8 months following the surgery for routine control for fusion or assessment. Then to our results, as I said, the time period was 40 months. We had 237 patients. The total number of pedicle screws was 1,352 screws. There was no significant baseline differences between the 3 groups. Screws placement rate was 1.9%. Complications were wound healing disorders, it was about 5%, CSF fistula 2%, pleural effusion 1%, and repleeding 0.4%. And the highest accuracy was in, or our analysis revealed that the highest accuracy was in robotic-guided surgery. More than 91% of robotic-guided screw placement or screws who were placed with robotic-guided surgery showed JRS grade A, and that was very accurate. And that was followed by fluoroscopy and intraoperative CT-based navigation. Revisions rate was 5.1%. There was no difference in regions of the spine, pathology, PMI, or bone quality. No differences between surgeons, between technique, open or cutaneous techniques. There was no difference between both of them. And there was significantly lower total radiation exposure in patients who underwent intraoperative imaging CT compared to fluoroscopy cases because they don't need a postoperative CT. The screw diameter and pedicle diameter were significant predictors of long course screw loosening. Small screw and pedicle diameters were associated with an increased likelihood of screw loosening. And the pedicle diameter less or equal to 12 millimeter and screw diameter less or equal to 6.5 millimeter were significantly associated with higher odds of screw loosening. To conclude, the robot-guided placement of pedicle screw compared to fluoroscopy-guided or intraoperative CT navigated technique has shown higher accuracy, less loosening rate, decreased revision rates, and the morphometric characteristic of screw and pedicle diameter showed predictive value of long-term screw loosening. Thank you very much.
Thank you so much. It was interesting presentation. You took a little bit more time, 1 more minute, but
sorry for that.
we will forgive you that. Okay, so we are back with Salman. Professor Sharif, please.